Picture a tiny tube, maybe 9 centimeters long,
Right.
just sitting quietly in your gut right now.
Right, doing absolutely nothing you'd ever notice.
Exactly. Most of the time, it's totally fine.
Yeah.
But because of this, bizarre anatomical quirk, this little tube acts like a ticking time bomb.
Because it relies on a single solitary blood vessel to stay alive.
Yeah, one vessel, and it has zero backup. So if that one road gets blocked, the countdown just starts.
It is, without a doubt, the ultimate abdominal emergency.
It really is. So today, we're taking you on a fast-paced deep dive into the clinical secrets of the appendix. We're pulling our insights straight from a source provided by the Surgical Thinking Academy, specifically their comprehensive clinical guide to appendicitis and appendiceal neoplasms.
And it is a phenomenal guide. Our mission today is to literally get into that surgical mindset. We want to understand exactly how this tiny organ fails so spectacularly.
Right, from spotting the hidden early warning signs of an attack, maybe even before a doctor does, to uncovering these rare, bizarre tumors that can literally turn your abdomen into jelly.
It gets wild, but to grasp why this structure goes rogue, we really have to rewind the clock.
Like all the way back to the 8th week of embryonic development, right?
Exactly. That 8th week is when the appendix first appears, basically as a little outpouching of the cecum.
Just a little bump.
Yeah, but as fetal development progresses, the midgut undergoes this really complex rotation. The cecum descends into the right lower quadrant of your abdomen, and it drags the appendix right along with it.
And it's not a uniform thing, is it?
Yeah.
I mean, we said it averages around 9 centimeters, but the guide notes it can vary wildly.
Oh, massively. It can be a tiny 2-centimeter stub or this massive 20-centimeter structure.
20 centimeters is huge for an appendix.
It is, but clinically speaking, the length isn't actually the primary concern. It's all about the diameter.
Right.
If you see a diameter exceeding 6 millimeters, that is a glaring red flag for pathology.
Okay, so anything over 6 millimeters is bad news. And because it varies so much in size and gets, dragged around during that embryonic development, it doesn't just sit in one predictable spot for everybody.
No, it is notoriously mobile. If you picture the cecum as a clock face, about 74% of the time the appendix is retrocecal.
Meaning it's tucked entirely behind the cecum.
Right, up at the 12 o'clock position. Then another 21% of the time, it drops down into the pelvis at the 4 or 5 o'clock position.
So it's basically hiding.
It really is. It can even be subhepatic, like resting high up near the liver, if that midgut rotation we talked about doesn't fully complete itself.
So wait, if it's hiding in all these different places, how do surgeons actually find it during an operation? Because they can't just blindly poke around the lower right abdomen.
No, they don't. Surgeons have a map. They trace the Tinea coli.
Those are the 3 longitudinal bands of smooth muscle that run along the colon ring.
You got it. If you follow those 3 muscular bands down the colon, they all invariably converge at one single anatomical point on the cecum.
Like X marks the spot.
Exactly. That convergence point is the exact base of the appendix. It's like a built-in biological compass.
That's incredibly cool. But the real structural flaw here, I mean, the reason this thing becomes a surgical emergency isn't its location at all.
No, it's the vascular supply. The appendicular artery is an end artery.
Which is such a massive design flaw. Let's visualize that like a dead-end street in a residential neighborhood.
That's a great way to put it.
Right, so the appendicular artery is the only road in. There are no side alleys, no alternate routes, no collateral circulation.
None at all.
So if a delivery truck breaks down right at the entrance of that dead-end street, nothing gets past it. The entire neighborhood is completely cut off.
And that lack of collateral blood flow is its ultimate vulnerability. Because when an obstruction blocks the lumen, the inside tube of the appendix, this rapid catastrophic sequence initiates.
The bomb goes off.
Basically, yeah. The appendix continually secretes mucus from its inner lining. But when the tube is blocked, that mucus has literally nowhere to go.
So it just fills up like a water balloon.
Exactly. The intraluminal pressure begins to skyrocket. This initial distension is what sets everything in motion.
Because that rising pressure inside the tube eventually exceeds the pressure of the venous blood trying to drain out of it.
Right. The veins get compressed first, so venous drainage stops, but the arterial blood keeps pumping in for a little while longer.
Oh, wow. So blood is going in but can't get out.
Yeah, which leads to massive vascular engorgement. It just swells. Eventually, the internal pressure overcomes the arterial pumping pressure as well, and that dead-end street is now entirely closed off.
And that's when ischemia sets in.
Precisely. Without oxygenated blood flow, the mucosal barrier starts to break down. The native bacteria that are naturally trapped inside, they multiply rapidly and invade the weakened appendiceal wall.
And if that pressure isn't relieved,
The gangrenous tissue simply gives way. The appendix perforates.
it bursts. So what are the delivery trucks, so to speak? What's actually blocking the road in the first place?
Well, according to the Surgical Thinking Academy guide, you can categorize the main culprits using the mnemonic FELT, F-E-L-T.
Okay, what does the F stand for?
F is for phacolith. It's a hardened, calcified stone of feces, and this is actually the most frequent cause in adults.
Sounds lovely. What about E and L?
E and L stand for lymphoid hyperplasia. See, the appendix is highly concentrated with lymphoid tissue. Following a viral illness, this tissue can swell dramatically and physically obstruct the lumen.
And this is the one that mostly affects kids, right?
By far the most common mechanism in pediatric patients, yes. Then, the T represents tumors, which are critical to rule out in elderly patients presenting with these symptoms.
Are there any other weird things that can block it?
Oh, absolutely. There are the outliers, foreign bodies like swallowed seeds, undigested barium from medical tests, or even parasitic infections.
Wait, really? Parasites?
Yeah, like Ascaris roundworms. They can physically crawl in there and become wedged in the lumen.
Okay, that is nightmare fuel. But regardless of what blocks the tube, the nervous system's response follows a very specific pattern, right?
It does. It's known as Murphy's triad. The sequence is pain, followed by anorexia, meaning loss of appetite, followed by vomiting.
Okay, I have to stop here because this sequence feels really counterintuitive to me.
How so?
Well, whenever I've dealt with a severe stomach bug or, like, food poisoning, the nausea and vomiting hit instantly, right? And then the generalized stomach cramps come later.
Yes, and that is a critical distinction that keeps patients out of the operating room unnecessarily.
So it's supposed to be backwards for appendicitis.
Exactly. In gastroenteritis, your typical stomach bug, the entire mucosal lining of the gut is irritated all at once, which triggers immediate vomiting.
Okay.
But appendicitis is entirely different because of how the body perceives visceral pain. When the appendix first begins to swell, it stretches the visceral nerve fibers.
The internal ones?
Right, and these fibers don't map to a specific pinpoint spot on the abdomen. They map to the T8 through T10 dermatomes of the spinal cord.
Which means what, exactly, for the patient?
It means your brain interprets this early stretching as just a vague, dull ache right around the periumbilical region.
The belly button.
Yes. It's only later, as the inflammation burns all the way through the full thickness of the appendiceal wall and starts irritating the outer lining of the abdominal cavity, the parietal peritoneum, that the pain migrates and sharpens.
So it moves from the belly button down to the lower right side.
Exactly. Down to the right iliac fossa, and it becomes severe and localized. The loss of appetite and the vomiting typically only kick in after this whole inflammatory cascade is well underway.
So if a patient is vomiting violently before they ever feel any abdominal pain, it's probably not appendicitis.
The statistical probability drops precipitously. Pain first, then vomiting. That is the rule.
That's such a massive clinical red flag for anyone listening to keep in mind. Pain first.
Always.
So once a clinician actually suspects the appendix, they deploy this whole series of physical exams to test that inflamed anatomy, right? Starting with the classic McBurney point.
Right. So if you draw a line from the ASIS, that's the bony hip point, the anterior superior iliac spine down to the umbilicus, McBurney's point is exactly 1/3 of the distance from the hip bone.
And pushing there hurts.
Localized tenderness right there suggests the inflammation has reached that outer abdominal lining.
But some of the other signs in the guide are incredibly mechanical and honestly kind of fascinating. Take the rousing sign.
That's a clever one. The clinician applies deep pressure to the left side of the abdomen, but the patient feels the pain shoot up on the lower right side.
Which sounds like magic, but there's a fluid dynamics reason for it, right?
It's pneumatic, actually. Pressing the left side displaces the column of gas resting in the descending colon. It forces that gas backward through the colon and down into the cecum on the right.
So you're basically inflating a balloon backward.
Exactly. That sudden pneumatic expansion of the cecum physically jolts the inflamed appendix on the right side, causing pain.
And then you have the position-based tests, which are directly tied to where we said the appendix might be hiding earlier.
Right. The psoas sign targets a retrocecal appendix. The patient extends their right hip back, which stretches the iliopsoas muscle. If the inflamed appendix is resting directly on that muscle, the friction causes severe pain.
And the obturator sign.
That targets a pelvic appendix. The clinician flexes the patient's right hip and internally rotates the leg. This stretches the obturator internus muscle right against the inflamed tissue.
It's all just mechanically poking the bear.
Basically, yes.
There's even the Markle sign, where the patient simply drops their weight heavily onto their heels.
Which sends a kinetic shock wave straight through the peritoneal cavity.
Or the Dunphy sign, where just forced coughing induces sharp right-sided pain.
Right. So clinicians aggregate all these physical findings with laboratory data using the Mantrol-S score, which is often called the Alvarado score. It quantifies the risk.
Let's break down how that score actually works under the hood, because it isn't just arbitrary numbers.
No, it's a very specific 10-point scoring system. You get 1 point each for the migratory pain, the anorexia, nausea, rebound tenderness, and elevated temperature.
Okay, that's 5 points.
Then you get 2 points for localized tenderness in the right lower quadrant.
Which brings us to 7.
The lab results make up the rest. 2 points are awarded for significant leukocytosis, which is just a massive spike in the total white blood cell count. But you also get a point for what is called a left shift.
The left shift. I found this fascinating in the text because it really shows how desperate the immune system is getting.
It's a great way to think about it. A left shift means the bone marrow is releasing immature neutrophils, often called band cells, into the bloodstream before they are fully developed.
Because it's losing the war.
Exactly. The body is burning through its frontline mature white blood cells so fast attempting to fight this infection that it basically starts deploying the biological equivalent of untrained cadets.
Oh, wow.
Yeah. If a patient hits a 9 or 10 on that Mantrel score, the diagnosis is highly probable.
And at that point, the focus shifts to imaging to actually confirm the target before cutting. But the approach here isn't one size fits all, is it?
Not at all. The gold standard for adult patients is a CT scan with contrast. It boasts a sensitivity of roughly 95%.
Pretty definitive.
Very. Radiologists look for that dilated diameter we mentioned, exceeding 6 millimeters plus wall thickening, and periappendiceal fat stranding, which just indicates surrounding inflammation.
And sometimes they can even see the blockage itself, right?
Yeah, occasionally you can spot the dense, bright calcification of the fecalith right there on the scan.
But CT scans do deliver ionizing radiation, so that forces a different protocol for more vulnerable populations.
Right. For pediatric patients, pregnant women, and particularly lean females where an ultrasound can easily penetrate the abdominal wall, sonography is the very first line.
And if the ultrasound is fuzzy or indeterminate during a pregnancy?
Then an MRI is utilized. It gives high-resolution soft tissue imaging without exposing the fetus to any radiation.
Makes sense. So once the imaging locks in the inflamed appendix, the traditional gold standard treatment has always been the laparoscopic appendectomy.
Right. 3 small incisions, dissect the appendix from its blood supply, secure the base, and remove the time bomb.
But there's a massive debate going on right now in the surgical world about an antibiotics-only approach, right?
There is. The Cartier trial from 2020 injected a lot of nuance into the surgical guidelines. It evaluated uncomplicated appendicitis, so cases where the imaging confirms no perforation, no abscess, and no severe peritonitis.
Basically, the bomb hasn't gone off yet.
Exactly. And they tested conservative management using broad-spectrum antibiotics instead of surgery.
And what did they find?
The data showed that at 90 days, the antibiotic approach was non-inferior. The acute infection resolved without the parent ever needing an operating room.
Okay, but the long-term data presents a pretty glaring issue. There's a recurrence rate of nearly 40% within the first year.
Yes.
So my question is, with a near coin flip chance that the infection is just going to come back anyway, why would anyone choose just the pills over a quick laparoscopic surgery? Aren't you just delaying the inevitable?
It's a great question, and it really comes down to weighing the physiological burden of surgery. Even a minimally invasive laparoscopy involves general anesthesia.
Which is never risk-free.
Right. Plus, there's potential damage to surrounding organs and the long-term risk of developing intra-abdominal adhesions, which are scar tissues that can actually cause bowel obstructions decades later.
Oh, I see.
So for high-risk surgical patients like those with severe cardiovascular issues, avoiding the physical stress of intubation and surgery is highly beneficial.
But for a healthy person?
Well, the high recurrence rate exists precisely because the underlying anatomical vulnerability hasn't changed. That dead-end street is still there.
The fecalith might still be sitting right there in the tube.
Exactly. You've suppressed the acute bacterial overgrowth with antibiotics, but the bomb remains armed, and that is exactly why definitive surgical excision remains the standard of care for the general population.
That makes total sense. But what about the scenarios where a surgeon actively decides they cannot operate immediately, even when the patient desperately needs it? Like if a patient waits days to seek medical attention.
Ah, right. If they wait too long, the appendix can slowly perforate, and the body will actually try to isolate the damage by forming a dense mass of tissue around it.
To trap the infection.
Yes, this is known as an appendicular phlegmon, or mass. The omentum, which is a fatty apron in your gut, and loops of the small bowel wrap aggressively around the necrotic appendix.
Just to prevent the infection from flooding the entire peritoneal cavity.
Exactly. Now, if a surgeon attempts an appendectomy at this exact moment, they are literally walking into a minefield.
Because everything is swollen and sticky.
The tissues are severely inflamed, edematous, and incredibly friable, which means they tear very easily.
The guide literally compares the structural integrity of the bowel wall at this stage to the consistency of wet tissue paper.
It's terrifying for a surgeon. Attempting to dissect that mass risks catastrophic iatrogenic injury, meaning surgeon-caused injury to the cecum or the small bowel. Sutures will simply pull right through the inflamed tissue, leading to a massive postoperative leak.
If they have to back off, they use something called the Oxner-Sharon regimen.
Right. It's essentially a high-stakes waiting game. The patient is admitted to the hospital, placed on IV antibiotics, kept strictly NPO, meaning nothing by mouth, and clinicians literally use a marker to outline the borders of the abdominal mass directly on the patient's skin.
It's just drawing a circle on their belly.
Yes, to monitor for specific S.P signs.
What are those?
If the patient's heart rate spikes, if their fever worsens, if the pain spreads across the abdomen, or if that physical mass expands beyond the marker lines on the skin, the conservative regimen has failed.
The abscess is spreading.
Right. And they must immediately proceed to surgery, just accepting those high tissue risks. But if the regimen succeeds, the systemic inflammation slowly subsides over several days.
And then they're cured.
No, the patient is discharged and instructed to return 6 to 8 weeks later for an interval appendectomy.
Ah, so they come back when things are calm.
By then, the omentum has retreated, the swelling is gone, and the surgeon can safely identify the anatomical planes and remove whatever is left of the appendix.
It's an intense waiting game. But not everyone can wait, right? Other demographics require immediate action. Like appendicitis during pregnancy is the most frequent non-obstetric surgical emergency encountered.
It is, and the anatomical displacement there is severe. As the uterus expands, it pushes the cecum superiorly and laterally.
It shoves it out of the way.
Right. So by the third trimester, the appendix can be wedged high up into the right upper quadrant, completely altering that classic pain presentation we talked about.
So the pain might be near the ribs instead of down in the pelvis.
Exactly. And conservative management with antibiotics is highly discouraged here.
Why is that?
Because the physiological changes of pregnancy can mask the signs of a rupture. And if the appendix perforates, the resulting sepsis dramatically increases the risk of premature labor and fetal mortality.
So they have to operate immediately.
The protocol mandates rapid surgical intervention regardless of gestational age.
Kids are another special case, right? They face a completely different mechanical disadvantage when dealing with a perforation.
Yes, and it involves that greater omentum we mentioned earlier. In an adult, the omentum is a large apron of fat and immune tissue that acts as the policeman of the abdomen.
It physically migrates over to wrap around the angry organ and wall off the infection.
Exactly, which is how those phlegmons are formed. But in young children, the omentum is short, thin, and underdeveloped. It simply lacks the mechanical length and density to isolate a ruptured appendix.
So when a pediatric appendix bursts, there's no backup.
There is no barrier. The purulent fluid disseminates immediately throughout the abdominal cavity, causing rapid generalized peritonitis.
Wow. Okay, so we've tracked the mechanics of obstruction, the inflammatory cascade, and all these complexities of surgical timing. But now we have to examine what happens when the pathology isn't an infection at all, but a neoplasm.
Right. Appendiceal tumors. They are exceptionally rare, discovered in only about 0.3 to 1% of all appendectomies.
And almost always is an incidental finding by a pathologist after the surgery is already done, right?
Right. The surgeon takes it out thinking it's appendicitis, and the lab finds the tumor later. The most prevalent subtype is the neuroendocrine tumor, or NET. Historically, these were called carcinoid tumors.
And they usually hide in a specific spot.
They have a strong predilection for developing at the very distal tip of the appendix, and the surgical management of a NET is dictated entirely by a rigid measurement threshold.
Let me guess, if the tumor measures less than 1 centimeter, the standard appendectomy that they already did is usually considered curative.
Spot on. But if the pathologist measures that tumor at greater than 2 centimeters, The biological behavior of the neoplasm completely changes.
It gets aggressive.
Yes, the risk of lymphatic metastasis increases exponentially. A simple appendectomy leaves potentially cancerous lymph nodes behind inside the patient.
So they have to go back in.
The patient must be brought back into the operating room for a formal right hemicolectomy.
Meaning the surgeon has to remove the entire right side of the colon, including the cecum and ascending colon.
Because they all share the exact same lymphatic drainage pathways along the ileocolic artery.
Wow. And the guide also mentions strange histological anomalies, like the goblet cell adenocarcinoma.
Yeah, that tumor exhibits a bizarre dual phenotype. It expresses features of both a well-differentiated neuroendocrine tumor and a highly aggressive glandular carcinoma.
So it's a hybrid.
It is, and because its clinical behavior is so volatile and unpredictable, the standard of care is extremely aggressive, usually defaulting straight to that right hemicolectomy.
Okay, but the most visually and mechanically staggering pathology in this entire guide involves the mucinous neoplasms, the lamino and AJM tumors.
Low-grade and high-grade appendiceal mucinous neoplasms, yes.
These are wild.
They are. These tumors proliferate inside the appendiceal lumen, but instead of forming a solid hard mass, the neoplastic cells continuously secrete mucin.
Which is basically thick, viscous jelly.
Right. And this jelly slowly inflates the appendix into what's called a mucocele. If the pressure becomes too great, or if the tumor erodes right through the wall, the mucocele ruptures.
But unlike a standard perforation that spills bacteria, this rupture spills viable, mucin-producing tumor cells into the peritoneal cavity.
And those cells, they implant themselves along the outer lining of the organs, on the surface of the liver, the spleen, the reproductive organs.
Like seeds.
Exactly. And they just continue executing their biological programming. They keep secreting mucin.
Which triggers a condition with the medical moniker jelly belly.
Yes.
I mean, that sounds almost cute, but it's actually terrifying.
It is deeply terrifying. The clinical term is pseudomyxoma peritoni, or PMP. It's an insidious, progressive disease where the entire abdominal and pelvic cavities become engorged with literally liters of gelatinous fluid.
And the sheer volume and hydrostatic pressure of all that mucin slowly compresses the gastrointestinal tract.
Until it eventually causes mechanical bowel obstruction and starvation.
And traditional intravenous chemotherapy is almost entirely useless here, isn't it?
It is, because intravenous drugs require a robust capillary network to deliver the toxins directly into the tumor. Mucinous tumors are largely avascular. They have very poor blood supply.
So the chemo just floats by in the bloodstream and can't get in.
The drugs simply cannot penetrate those dense gelatinous masses. So the treatment protocol demands a highly specialized, grueling intervention known as the sugar-baker procedure.
It starts with cytoreductive surgery, or CRS. The surgical team spends hours methodically stripping the peritoneum from the abdominal wall, right?
Yeah, and resecting any organ colonized by the tumor implants. That often means removing the spleen, the gallbladder, and entire sections of the bowel just to eliminate all the macroscopic visible disease.
And once the visible tumor burden is finally cleared, the team initiates HIPEC, heated intraperitoneal chemotherapy.
Right. Large inflow and outflow catheters are placed directly into the open abdominal cavity. The surgeon literally perfuses the abdomen with a highly concentrated solution of cytotoxic drugs, typically mitomycin C or oxaliplatin,
And they heat it up?
to exactly 42 degrees Celsius.
42 degrees. The heat is the functional key to the entire process, right?
Absolutely. The hyperthermia induces local vasodilation and actually alters the lipid bilayer of the remaining cancer cells. It dramatically increases the permeability of their cell membranes.
Oh, so it melts the armor.
Essentially, yes. This allows the large chemotherapy molecules to penetrate the microscopic tumor nodules left behind on the tissues, reaching depths that intravenous delivery could never, ever achieve.
And the abdomen is just bathed in this heated, toxic solution for up to 90 minutes before being drained and reconstructed.
It is one of the most metabolically demanding procedures a human body can undergo, and it all originates from a microscopic cluster of aberrant cells in a 9-centimeter tube.
It is unbelievable. We've traced the entire lifespan of this anatomical hazard today, from the dead-end embryological vascular supply that makes it so prone to ischemia, to the highly structured nerve pathways that dictate the exact sequence of Murphy's triad.
We explored the mechanics of the mantral score, that intense immunological battle requiring interval appendectomies, and the sheer extremes of treating mucinous neoplasms with heated chemotherapy.
You now possess a comprehensive understanding of the pathophysiology and surgical strategy behind the ultimate abdominal emergency. But there is one final, lingering mystery drawn from the clinical data that completely upends how we view this organ.
The immune function.
Right. The appendix is heavily packed with active lymphoid tissue, and that tissue reaches its absolute maximum density and volume right between the ages of 12 and 20.
Which perfectly aligns with the mechanical explanation of why appendicitis peaks during adolescence. There is simply more hypertrophied tissue available to occlude the tube.
But the clinical literature also documents that after age 30, this lymphoid tissue undergoes strict involution. It physically shrinks, atrophies, and just fades into the background. So if the appendix is truly just a useless vestigial remnant of human evolution, why does it function as a heavily fortified, highly active immune organ during the precise developmental window when we transition from childhood to adulthood, only to deliberately shut itself down once we enter our 30s?